All right, why don't you go ahead and get started?
All right, thank you so much. So hi everybody, my name is Vic Roy. I'm one of your first year nephrology fellows here at University of Colorado. So thank you all for coming for my grand rounds. We're going to be talking about pregnancy dialysis versus transplantation. And real quick before I kind of start, I always like to start off with something fun. So as you all know, it is the most important time of the year. The Super Bowl is coming up, so kind of wanted to just bring this up so everybody knows that we have a few important games this weekend, and here are some of my predictions. And I think it's going to be the Chiefs and the Rams in the Super Bowl, and I honestly think that the Rams are going to win the Super Bowl this year, and it's going to be Matthew Stafford's first Super Bowl. So there's that. Okay, we got that out of the way. So kind of the background on my talk here. So pregnancy is uncommon in women with ESRD. Fertility rates are pretty low for women on dialysis. And the general rule of thought is that when you counsel women with ESRD on pregnancy, it's basically you're telling them that sometimes it's going to be difficult for them to have children. So kind of going off of this topic, I actually know somebody personally who actually had a pregnancy while she was on dialysis, and subsequently this same person also was able to have a child after she had a transplant. So I thought that this was a kind of an interesting topic and something that us as renal fellows and the rest of the faculty, I think it's something for us to kind of know and see what we can kind of do about it in whenever this kind of comes up in our future. So kind of the advancements of dialysis and OB care kind of led to the improved live birth rates of women on dialysis. So pregnancy for young women with ESRD is actually now more feasible and safer than was thought initially before. So kind of the objectives of my talk here is, how do we approach a patient who has ESRD and wants to become pregnant? Transplant or dialysis, which one is more preferred? And if you have a patient who is wanting to become pregnant on dialysis, what do we need to do? And then the same thing if we have a patient who has a kidney transplant and they want to become pregnant, what do we need to do? So we're going to start with a quick little case here. Excuse me. We have a 22-year-old female who comes to the office, wants to discuss plans for pregnancy. Her PMH includes ESRD, which is secondary to post-infectious GN. She's been on PD at home, so peritoneal dialysis, for the past year and a half. Very compliant with both PD and rest of her medical treatment. Rest of her medical history, she has hypertension and hypothyroidism. Otherwise healthy, no real history of PD-related complications or ESRD-related issues. And as a side note, she can make about 500 to 1,000 milliliters of urine a day. So the medications that she's on. So she's on losartan, she's on calcitriol, sevelamer, she's on levothyroxine, 75 micrograms. No contraceptives or anything like that. Her vitals are stable on exam, 120/70s, heart rate's in the 80s. Rest of her vitals are stable. On physical exam, no real findings, no edema, no abdomen findings. Her dialysis catheter as well, there's no kind of drainage or signs of infection. Labs, other than a creatinine of 3, pretty much normal, B1 in the 20s, phos, mag, potassium, all within normal limits. And kind of for the purpose of her talk here, she's G0, P0, A0, and her last normal menstrual period was 2 weeks ago. She has no issues with these. So let's kind of stop here and let's quickly just kind of go through what we kind of need to think about in order to help guide this patient. So what are the things that we actually need to do and need to think about for this patient? What's the data behind the success rates of pregnancy for patients with ESRD? And are there any changes that need to be made from our perspective in order to aid in this patient having a successful pregnancy? So a little bit of history, a little bit of background. The first year somebody with ESRD had a successful pregnancy that was delivered was actually 1971. And this was outlined in a paper by Confortini et al. Titled Full-Term Pregnancy, Successful Delivery in a Patient on Chronic Hemodialysis. This was done in 1971. Apparently the outcome of the child, they did well. It was a little premature, but other than that, no other issues. Several studies since then, up until the 2010s, show that CKD leads to a lot of adverse fetal and sometimes maternal outcomes. So that's kind of something important that we, as renal physicians, maybe kind of took with us when we talked about pregnancy in ESRD patients. 37% was a successful outcome rate in the 1980s, which you can think like is very, very low. But ever since then, our success rates have been increasing with patients on dialysis who are pregnant. In fact, in 1998, that number was about 50%. However, in the last 10 years or so, the number's in the 80s, which is comparable to live birth rates in the general population, which is something we'll get into a little bit later. So why is it more difficult for women to have a successful pregnancy or even conceive when they are ESRD? So a lot of it has to do with the physiology. So fertility in women with CKD diminishes as the GFR rate declines. And actually you have a lot of menstrual cycle irregularities once your GFR is 15 or below. And once you kind of reach this ESRD stage, most women actually become anovulatory, even if you do have regular menstruation. And this is thought to be because of uremia, and which actually leads to dysregulation of the hypothalamic pituitary gonadal axis. And other things that kind of factor in is that what you have here is a lot of prolactin, which kind of inhibits GnRH in the hypothalamus. And you kind of need this in order to have an LH surge, which kind of leads to ovulation. And the reason that you have a lot of prolactin in the system when you have CKD is because prolactin is cleared by the kidney. So if you're not having good clearance of prolactin, you're going to have a lot of buildup. This buildup is going to lead to inhibition of GnRH. You're not going to have your cyclic LH release and LH surge, and you're going to have anovulation. And so I really like this picture that I got actually from Nature. It kind of shows that you have baseline kind of LH levels that are elevated in CKD patients, and when you compare it to regular patients without ESRD or CKD, you'll see that they have this ovulation phase where you have this LH surge, and you don't have that in CKD. And that's kind of one of the biggest reasons why you don't have ovulation, or you have low successful pregnancy rates. It's interesting to kind of say that, to see that, with these type of issues, with HPO axis issues, you'll have your menstrual cycle irregularities and ovulation. You can also have decreased libido, and obviously this impaired fertility. Patients with ESRD actually do have earlier onset menopause, about 4.5 years compared to the general population. And among women on hemodialysis, about 73% actually have menstrual disorders, and half of them have amenorrhea. So kind of going from here with our patients, there's three kind of big things that we want to discuss with our patients, and kind of three big phases of treatment. So initially, you want to talk about preconception care, counseling. These kinds of things would be, contraceptive use, family planning, those kinds of things. And then once your patient decides to go forward with pregnancy, there's management that we have to talk about with that, and then obviously the delivery phase. So from here, we'll go into preconception counseling and considerations. So initially, there's kind of two paths you want to talk about whenever a patient comes in wanting to start a family. You either say, we can talk about waiting until you have the renal transplant, and we'll kind of get to that later in the talk, or you can choose not to wait for a transplant and become pregnant at this time. And that's what we're going to focus on for the time being. Now, when this happens, you want to inform your patient that pregnancy and dialysis is considered high risk. You'll need to have a multidisciplinary effort with a team that involves high risk OB as well as a nephrologist. You also want to inform that, it is more difficult for them to become pregnant, and that's kind of because of the physiological changes that we talked about a couple slides earlier. And also sometimes a fertility expert may be necessary to kind of help facilitate pregnancy. So like I said, when it comes to preconception considerations, you want to talk about contraceptive use, but that's not something we're going to be discussing in this talk today. The topics that we're going to be covering more are medication management and pregnancy outcomes. So medication management, you want to obviously perform a thorough medication review and medication reconciliation. You want to make sure that you see all the potential teratogenic medications. So in our patient, they're on a RAS inhibitor. That's something that we would want to stop and maybe transition over. And what we could do is maybe change it to methyl-dopa, labetalol, or long-acting nifedipine, which are considered pregnancy safe antihypertensives. You want to target that blood pressure of 140/90. Another thing is, you want to initiate folic acid 5 milligrams daily. You also want to make sure that your patients are taking their usual prescribed renal multivitamins as necessary. And you want to optimize other comorbid conditions. So diabetes, lupus, things like that, get those under control prior to moving forward with pregnancy. And on top of that, you want to also make sure that some of these medications are optimized. So if they have hypothyroidism, like our patient does, you would need to increase the thyroid medication dose. And then you can also stop phosphate binders. So there's no known teratogenics in terms of phosphate binders, but the reason for stopping it is something that we'll get to in a little bit. The type of dialysis that we do in these patients, at that point, you can kind of stop phosphate binders. So we'll get into that. So pregnancy outcomes, as we stated kind of a little bit earlier, they're rising for ESRD patients who are pregnant. And a lot of this has to do with teaming with high-risk OB as well as nephrology. But what are some of the fetal outcomes that pregnant ESRD patients kind of face? So this is a paper that was done by a group called Piccoli et al. It's the paper's called Pregnancy and Dialysis. It's a systematic review and meta-regression analysis. And kind of correlates dialysis schedules and pregnancy outcomes. And this was actually done in 2016. Now, the end of this paper was actually 107, and you can kind of figure that out by going through this, but there was 93 patients that were on dialysis, either dialysis started before conception or dialysis started after conception, hemodialysis, sorry. And then there was actually some PD patients in this case, albeit it was only 14 cases, but they still did have a caseload of PD in this paper. And basically what they were kind of looking at was different fetal outcomes, maternal outcomes, adverse effects, all these different kinds of things. And I think the paper does a great job of kind of putting together all these kinds of tables, and we'll be referencing this in a little bit again. But basically this, what I'm using this part for is kind of bringing up kind of fetal outcomes. So risks of the fetus include early delivery, which can be because of fetal-related issues such as non-reassuring fetal heart tones, intrauterine growth retardation, abnormal Doppler exams, and these things can count about 24%. And then other risks of the fetus kind of include maternal causes of risk, which could be placental abruption, hypertension, preeclampsia, and these can kind of account for also about 20%. So you have about a 1/4 risk to the fetus in terms of non-reassuring fetal issues, but you also have about a 1/5 chance of having fetal risks from a maternal standpoint. Kind of important to note here that there was actually about 3 deaths, unfortunately, in this trial from in terms of infants on HD. And that's kind of something that you would want to talk about with your patient, that they actually do have an increased risk of death. And in this paper, when it comes to infant deaths, so about 107 patients in this trial, so that comes about to 2.8 to 3%, where in the general US population, the death rate, unfortunately for infants, is 5 out of 1,000 live births, or about 0.5%. So you do have an increased risk of fetal demise being on dialysis. Now, just want to clarify, this on PD, there's only 14 patients on this trial, but this doesn't really tell most of the story. So that's kind of, you have to take that part with a grain of salt. So this kind of just shows us that pregnancy as an ESRD patient is very high risk, and patients need both, high risk OB and nephrology to kind of team up and help and make sure that we're doing the best for our patients here. So other kind of, so say your patient, does get pregnant, and you want to monitor them and keep an eye on them. So what are some of the things that we kind of have to do? So monitoring is number one. And when it comes to monitoring, you want to make sure that, you have maternal monitoring, fetal monitoring, talk to them about nutrition, infection, and anemia risks. So fetal monitoring, that kind of happens more with the OB side of things. However, we do want to monitor them as a nephrologist from the dialysis side. And we'll talk about that in just a second. Nutrition, now this can be an entire topic, honestly. When I was kind of doing my research, I mean, there's papers all over the place that kind of talk about nutrition in ESRD patients, nutrition in pregnancy. And so kind of what I took home from that is that you want to liberalize protein intake, which will help kind of facilitate growth of the fetus. And actually what you want to do is you want to target a protein intake of about 1.5 to 1.8 grams per kg per day, which is actually higher than non-CKD pregnant patients. And the reason of that is something that we'll get into in a little bit. And then the other thing is you also want to liberalize FOS in the diet. So again, you want to monitor these patients for infections. They're a higher risk as opposed to non-ESRD patients. And that's, kind of related to access issues, and even UTIs can also pose a large risk for these patients. Anemia is also something that, we want to keep an eye on, especially in these patients, because there's several factors that can contribute to anemia and not just ESRD. One of them can be a relative EPO deficiency due to high demand of RBC production for placental and fetal growth. You also have loss of iron in RBCs with dialysis, and EPO resistance from inflammatory cytokine production. So kind of a side note on anemia, especially in this patient, when they're thinking about renal transplant in the future, in up to 25 cases of anemia in pregnancy, and this is kind of just in the general population, they may be severe enough to require a blood transfusion. However, when it comes to blood transfusions, this is a sensitizing event. And especially with pregnancy, which is also a sensitizing event, these two things can kind of make transplant in the future a little bit more risky, a little bit more, could have patients at a higher risk for rejection. Now, this kind of paper over here, I just put this in here. red RBC transfusion in and of itself wasn't associated with rejection, but it can carry an increased risk. So for graft loss. So that's kind of something that we want to think about in these patients as well. Another side note is kind of just preeclampsia and hypertension. I know this is a big topic, and unfortunately, in the interest of time, won't get too much into it. But you have to be careful with preeclampsia, especially in ESRD patients, because of hypertension and proteinuria. And basically, what preeclampsia kind of happens is because of maternal and placental vascular dysfunction. So, these patients are at higher risk than the general population. In the same paper that we talked about earlier, Piccoli et al., about 12 out of 107 of those patients experienced preeclampsia, which was about 11%, and general population is about 4%. So most of these patients, you will need to start 81 milligrams of aspirin about the 12th to 13th week of gestation and kind of continue until delivery. And this is a 2B, grade 2B recommendation. So when it comes to other outcomes, so we talked about fetal outcomes, maternal outcomes. So a big point over here is that there was no deaths that was associated with this on the maternal side. But there were other outcomes that kind of came out, and this is, remember, this is that same Piccoli et al. Paper that I referenced to earlier. So other things that happened, patients had hypertension, which was about 54%, hydramnios, which is about 18.6%, and anemia were the three biggest things seen. But you could also have things like pelvic abscesses, pulmonary edema, cardiomyopathy, heart failure, and all of these kinds of things were seen about 2 to 6% of the patients seen in this study. So there is significant risk to the fetus in terms of ESRD, and then there are some risks that are associated for the maternal side of things as well. So the management of ESRD, this is a big topic here. We'll talk about dialysis prescription targets, and we'll also touch on PD a little bit. So when it comes to changing dialysis, in almost all of the cases, you will definitely need to change your dialysis prescription. And how do you do that, and what do you kind of do? So what you'll kind of need to do is target a more frequent and or longer dialysis sessions. So this is going to be about 5 to 6 times a week. So, and you usually want to target about 36 or so hours. And kind of the reason of this is multiple folds. So, higher BUN levels is actually related to fetal demise. And you'll be inducing this by having your patients ingest more protein. And this is because, you want to help the fetus grow. So, this is something that's very important, is that we need to increase the frequency and the amount of dialysis that these patients receive. And the data behind that, this was done by a trial by Huludinowicz et al. It's called Intensive Hemodialysis Associates with Improved Pregnancy Outcomes. And this was kind of a retrospective study that was done in 2014. It looked at pregnancy outcomes in the US and in Canada through 2000 and 2012. And they kind of compared the outcomes off of time on HD per week. And so the issue with this paper is that overall, there was only 21 patients that they were able to get from Canada on the 37 hours or more chart here. And then there was about 71 patients on the American side, which kind of fit in between the less than 20 hours and 21 to 36 hours. And kind of when you stratified it by time, you saw that the live birth rate was about 48% in women who received about 20 hours of hemodialysis per week or less, and about 85% in women who received about 36 to 37 or more hours of dialysis per week. So, even though there was some issues with numbers, the percentage rate is actually pretty impressive. And not only in that, in this middle kind of ground here, 21 to 36 hours, you do see that it hits about 70%. So what you can kind of glean off of this is that more dialysis equals higher successful pregnancy rates. And this kind of has been what we've been targeting, and kind of how we go about with dialysis is that we want to target more intense, more frequent, and more hours of dialysis. And so kind of when it comes to prescription, you want to keep the potassium about a 3 bath. This is to reduce the risk of hypokalemia. Again, you're going to be frequently dialyzing this your pregnant patient, so you'll have less a risk of having hyperkalemia. Bicarb, you want to keep at 30 to 35. Calcium, you want to keep at 1.5. Now, when I was kind of looking through the reasoning behind that, some of the stuff that I kind of saw was you'll have increased kind of bone turnover due to all the hormones that are going on because of pregnancy, such as estrogen and progesterone and those kinds of things. So you might have a little bit higher calcium, so you want to kind of decrease that calcium bath. And again, you're going to be not imposing a phosphate restriction on these patients, so they can increase dairy as well as kind of increase calcium from there. And another thing, it's not really a target, but sometimes you'll need to add sodium phosphate to a bath for your dialysis patient, and this is because you're aiming for a phosphate goal of 4.5. And again, if you're frequently dialyzing this patient, you can run into low phosphate levels overall. So that's why you want to make sure you add sodium phosphate if needed for these patients. Other targets, so BUN we kind of talked about a little bit. Some say keep it less than 50, but there are some other papers that kind of say keep it less than 35. Not too many studies that are kind of done, but one of them kind of stated that there's a direct correlation with fetal mortality and elevated BUN levels. So once BUN concentrations reach 60 or greater, there was actually no live births that were documented, which I think is kind of interesting to think about. So with these patients, you want to be on the safe side, keep their BUN levels low. And then in terms of dry weight, so dry weight is going to increase throughout the pregnancy. You have a fetus that's going to be growing. In your first trimester, you're going to expect to see about 1 or 2 kilos added to the dry weight. But once you get into the second and third trimesters, you can have about 0.5 kilos a week increase. So these patients, you need to kind of monitor closely, especially in their second and third trimesters. Adjust their dry weight based on their blood pressure, volume status, and nutritional status, and use UF as necessary to kind of meet these goals. So these numbers aren't fixed, but it's kind of a guideline to kind of go off of. So in our patient, PD is our initial modality, but what are some of the risks and benefits of PD versus hemodialysis? So PD versus HD in some ways can be beneficial for pregnancy. It's continuous and it's gentle UF. It's done nightly or daily, however your patients kind of do it. You avoid systemic anticoagulation, which is found in HD. You have less overall instances of anemia, metabolic balance, and you can also have good outcomes because the patients aren't coming into dialysis every day. They're not having needles placed. They're not in the vicinity of a lot of other people. However, when it comes to the data, there wasn't so much that was found or reported between like the 1980s and the 1990s. And at that time, that was people were pushing more for HD because we didn't really have that much information. But with more kind of intensive dialysis and things like that, that's kind of changing. When it comes to PD, there can be some severe complications. Peritonitis could conceivably damage fallopian tubes. However, it's kind of interesting that the rate of ectopic pregnancies reported in this population isn't increased. but that could harm the patient down the line if they want to get pregnant, or if they have a renal transplant or something like that and want to have a child. Other things to kind of think about: hypertonic solutions in the intraperitoneal space can interfere with ovum transport, and kind of just with having a growing child, you'll have patients who complain of abdominal fullness, discomfort. You can also have some catheter drainage difficulties, as well as polyhydramnios. So this can lead to progressively lower fill volumes because of discomfort, and at that point you might not be able to have kind of good dialysis for these patients. Now, when it comes to some of the severe risks, if you have bloody dialysate in these patients, that could indicate like an obstetric catastrophe, which could be like placental abruption or kind of trauma from the expanding uterus on the peritoneal dialysis catheter. So that's kind of something to look at. If there is bloody dialysate, that means they have to go get seen by OB or surgery right away. Preterm delivery, premature rupture of membranes, and stillbirth can also be some results that can be seen from acute peritonitis. So that's why we have to be a little bit more cautious and careful with these PD patients and make sure that they come in frequently to kind of see both us and high-risk OB. Now, this is kind of a big paper. This kind of compared different rates of maternal and fetal complications from different papers from 1983 all the way down to 2017. And this is all patients on peritoneal dialysis. So as you can see, a lot of premature births, even in the early stages of this, of PD patients on pregnancy, and not too many fetal kind of demise type of outcomes. There was one stillborn that was reported here in 1992, but kind of since then, a lot of the patients were kind of born prematurely. And in terms of maternal complications, not too many issues seen here, maybe anemia, some premature rupture of membranes, hypertension, things like that, but nothing too kind of concerning. So this kind of is a little bit reassuring that, you can have a patient on PD and still become pregnant. So when it comes to your PDRX for these patients, you want to do less volume, and this is kind of a caveat to this. This is more for third trimester, end of second trimester and third trimester. You want to do less volume, about 1.5 to 2 liters, and you want to do more exchanges so you get that good dialysis kind of going. And the reason that I kind of added this, that this is only for third trimester, is that there's not too much data when it comes to the first and second trimesters. And likely you can probably keep your regular home PD prescription for these patients and modify as needed down the line. And I think this is because more of, you have a growing child that's in the pelvic cavity. As that expands and gets bigger, these are the changes that you need to make. That way you can kind of make sure your patient isn't uncomfortable. Residual renal function is important in overall outcomes, and it kind of aids in volume status and electrolyte abnormalities. So that's kind of important, especially like our patient over here who can make about 1 liter of urine a day. You'll see improved pregnancy outcomes with patients who still have preserved renal function. However, when it comes to PDRX, you have to go case by case, and you have to make sure that the same parameters are met. Patient A is not going to be the same as patient B. So it takes a lot of fine tuning to make sure that we reach those parameters, the BUN, the phosphate, all those kinds of things. So it takes a lot of kind of planning to go forward. Now, the overall recommendation in the United States so far that I've seen is that we encourage HD over PD. Now, in some countries, that's a little bit different. Like, for example, in Malaysia, I saw a paper that said that their recommendation is PD over HD. But again, there's not too much data that kind of tells the full picture of these things. You know, we do have your fetal and maternal risks and outcomes, but it doesn't tell us, the numbers aren't as large as we'd like them to be. And then, you know, most of these studies are kind of retrospective and or case studies, and a lot of them include more HD patients than PD patients. You know, again, a couple of slides ago when I was showing you those two images, those are small case reports, you know, 1 to 5 patients at the most. So it's kind of hard to have good recommendations based off of those papers. So the last thing I want to talk about in your HD patient and your dialysis patient is delivery. So preterm delivery, you know, that's something that we saw a lot of on some of these papers. It may be necessary in the presence of severe preeclampsia, fetal growth restriction, and or non-reassuring fetal heart tones or fetal distress. However, you know, most women that are on dialysis, you know, they will be expected to have delivery about 37 weeks. You know, there's little benefits in allowing the pregnancy to extend beyond these 37 weeks. And this is kind of due to increased maternal and or perinatal risk. Delivery needs to be timed because, you know, if you're on hemodialysis, your patient will really receive heparin. So you kind of need to time it in a way where, you know, they get dialyzed and then they have more than about 12 hours until they deliver. Most patients can safely undergo induction of labor and vaginal delivery. And, you know, obviously C-section is there for indications. You know, the other thing to kind of think about is magnesium. A lot of women receive magnesium prior to delivery, either to prevent seizures and preeclampsia, or it's to reduce the risk of cerebral palsy before preterm birth in infants who are less than 32 weeks. As we know, magnesium is renally excreted, and, you know, toxicity can be life-threatening. So for those who do require mag, you know, you want to make sure you reduce the loading dose and the infusion by 1/2, and you closely want to monitor these serum levels. And then if magnesium is needed during the delivery phase, you want to make sure you do a good amount of dialysis right afterwards. So for our patient, kind of to wrap this part up, is they decided to forego transplant. They became pregnant about a month later. They continued on PD with follow-up every 2 weeks with either us or high-risk OB. They were able to stay in the parameters and targets, albeit with a little bit of fine-tuning in terms of peritoneal dialysis. By the 3rd trimester, not 3rd cycle, the fill volume was about 1.5 liters and the patient was on 6 exchanges. They delivered a vaginally healthy baby boy, no negative outcomes at 37 weeks. So any questions this far? This is a little kind of summary slide that I was able to find through one of my papers. Kind of talks about everything that we just talked about. All right, so we're going to move on to the next and final case. So it's the same patient. You know, she had a successful pregnancy. The child is healthy and well. Subsequently, they found a living donor for a kidney transplant, and the patient is now 4 years status post-renal transplant, and they're looking to get pregnant again. So she's about 27 years old. She's doing well overall. She's compliant with her medications. There's no evidence of graft failure. Her surveillance biopsy showed no acute or chronic signs of rejection. She's on tacrolimus 1 BID. She's on mycophenolate 720 BID, prednisone 5, no other medications, no hypertension, things like that. Her exam, vitals, everything, all that kind of stuff is normal. No graft tenderness, no lower extremity edema. Creatinine was established at a baseline of 0.9. Her BUN is less than 20. And the rest of her labs, exam, everything is basically normal. So how do we advise this patient? So we kind of go about our same checkpoints as we did before with your patient that was on dialysis. You talk to them about preconception counseling, contraceptive use, and then, you know, once it gets to pregnancy, you know, we want to do monitoring and things like that, change medications, and then postpartum wise, you know, we'll touch base with them at one point after that. But you always start with preconception. But before we get into that, a little bit of history kind of on renal transplant patients and pregnancy. So the first successful pregnancy actually occurred in 1958 in a patient who had a kidney transplant. This is a 23-year-old, her name was Edith Helm. She received a kidney from her identical twin sister in 1956. And 2 years later, she delivered a healthy full-term boy by C-section. Interesting to actually note is that her sister, who donated the kidney, was able to give birth 4 times after donating that kidney. So she was able to do it on 1 kidney. Now, when it comes to patients who are kidney transplant recipients, it's still considered high risk, kind of given the multiple factors that are going on for both the mother and for the fetus. You have immunosuppression, hypertension, potentially teratogenic medications. So it kind of takes a big group of people to make sure that we're doing the best for our patient over here. So when it comes to that, there's not too many studies that are done in this population, unfortunately. And it's kind of like the dialysis population. A lot of these studies are retrospective and they have relatively small patient numbers. So that's kind of something to think about. So when it comes to preconception counseling, we talked about the physiology before in terms of CKD patients. However, once a patient gets transplanted, their sexual function actually improves within a few weeks, and the HPO axis hormones start to kind of normalize back to pre-CKD levels. And this is kind of why, we talk about contraception in these patients to make sure that family planning is there. Talk about it before transplantation, talk about it after transplantation, and then adjust when the patients want to get pregnant. The thing to kind of talk about though is that in terms of optimal time for contraception conception after kidney transplantation, it's uncertain. So the general rule of thumb is that you want to wait 1 year after you get pregnant or after you have a transplant to get pregnant. But in the past, the thought was you want to wait 2 years post-transplant. And that's kind of been changing. And actually now we've also seen that you can consider 6 months after transplant. And that kind of just depends on your immunosuppression regimen and kind of the conversation that you have with your patient and the transplant nephrology team. But when it comes to things like CMV infection, if they have had a recent CMV infection or if they're active or things like that, you want to make sure that the CMV is resolved at least 6 months to a year prior to kind of thinking about conception and things like that. So monitoring is a little bit different in these patients. There's a lot of different things we need to make sure that we're not missing. So, in terms of immunosuppression, these immunosuppressive drugs can have an effect on the fetus. You can have preterm birth and malformations that can kind of happen with some of these medications. But from the maternal side of things, we want to make sure we don't miss rejection, we don't miss hypertension, and we want to keep an eye out for infections and diabetes, especially in this population being on, glucocorticoids. Immunosuppression can kind of lead to infection. So these are things that we want to kind of make sure we keep a close eye on. And so in terms of that, we want to make sure that we monitor these patients about every 2 to 4 weeks by either us, transplant nephrology, or high risk OB. And kind of in terms of high risk OB, some of the things that they'll do is that, they'll test for trisomy 13, for example, fetal aneuploidy. And they'll make sure that those things are kind of taken care of and checked. But what we need to make sure of is that we keep a close eye on things like hypertension, preeclampsia, rejection, obviously, diabetes, and infection. And it's also kind of important to note, once you hit that second trimester of pregnancy, that you can have immunosuppression levels drop. So this is why at that point, you definitely want to follow them every 2 weeks, especially once they hit the second trimester mark. That way you can kind of adjust immunosuppression levels, which we'll kind of get into in a little bit. So medications, a lot of these medications, you have to kind of go through, check to make sure that they're not teratogenic. And so for most of these patients, you'll have to modify their maintenance immunosuppression. These medications kind of cross the maternal fetal barrier to different degrees, but almost all of them can carry some sort of risk in pregnancy. And when it comes to a good medication regimen, what you want to do is you want to have a calcineurin inhibitor, so either tacrolimus or cyclosporin. These are okay in pregnancy. And instead of mycophenolate, you want to do azathioprine, and you can still kind of continue your low dose prednisone. And the reason that we don't want to do mycophenolate in these patients is because there's an increased risk of first trimester pregnancy loss, and it can have congenital neural tube malformations. Other medications that are contraindicated in this population are mTOR inhibitors, sirolimus and everolimus. These are both category C medications. And when it comes to medication levels, there's not that much data out there that I've seen that kind of says to target certain levels or not. You can keep your target levels from prior to pregnancy in these patients. Again, once they reach the second and third trimester, the immunosuppression levels can fluctuate. So this is why you need to kind of keep a close eye on them in order to make sure they're meeting those immunosuppressive goals. Other kind of medications that are that we should consider. So patients who have rejection or things like that, you want to keep a close eye on them. But things like IVIG, Rituxan, and plasma exchange are generally considered safe. However, when it comes to antibiotic prophylaxis, trimethoprim, dapsone, inhaled pentamidine, they're generally avoided and contraindicated in pregnancy. So doing a good kind of med rec for these patients is very important. That way we're not missing things and not giving potentially teratogenic medications to these patients. So this slide I got from Gonzalez Suarez et al. It's called Pregnancy and Kidney Transplant Recipients. This was done in 2020 in Mississippi. And actually, this group, they actually have done quite a few different studies in terms of CKD and ESRD, transplant patients and pregnancy. So this slide kind of talks about all the different outcomes in terms of maternal outcomes, pregnancy outcomes, and fetal outcomes. Obviously you're going to have a higher risk of hypertension in these patients. And because of that, you're going to have a higher risk of preeclampsia in these patients. So as you see, there's about a 21 to 30% rate of preeclampsia in these transplant patients, as opposed to about 4% in the general population. So that's a risk that we're going to have to talk to our patient about if they want to get pregnant. Interesting enough, gestational diabetes, only 5 to 8% as opposed to 9% in the United States population. I think that's probably because, we monitor these patients that are on medications, and you kind of keep a close eye on them from that standpoint. When it comes to acute rejection, the number is pretty large, or the range is pretty large in this population. 1 to about 9.4% in kidney transplant patients when it comes to that, and in postpartum you'll have about a 1.3% chance of a rejection. It's just that we don't have enough numbers to kind of make a good, accurate kind of prediction of rejection in these patients. When it comes to fetal outcomes, most of them, they do pretty well. There is a 4.5% birth defect chance seen in your kidney transplant patients. I kind of looked on the website. I just kind of Googled birth defects in the US population. And that number is actually about 2.9 to 3.3%. So it's pretty close, but it's still a little bit increased risk of birth defects in these patients. And when it comes to pregnancy outcomes, as you can see, about 74% of live births happen in your kidney transplant patients. And this is when you compare it to the United States population of 62%. Obviously, that number can be related to multiple different factors, such as abortion and things like that. But it's kind of interesting to see that your live birth rate or your percentage in these patients is not terrible. So it's actually reassuring for your patient who is a kidney transplant patient. There are miscarriages, but it's comparable to the normal population. One thing I kind of wanted to point out here definitely is neonatal death. It's about 1.4 to 3.8% in your transplant patients, whereas it's only about 0.4% of the US population. So there is an increased risk of neonatal death in a patient who has a kidney transplant and wants to get pregnant. So this is definitely something we'll need to talk to them about. And another thing is preterm birth, 43 to 51% in your transplant recipients, as opposed to 12.5%. So, excuse me. So you will see a higher risk of preterm birth in these transplant patients. So rejection, we're kind of winding down here, a few more slides. Reported rates of kidney allograft rejection are generally comparable between pregnant and non-pregnant transplant recipients. Pregnancy in and of itself is a state of immunological tolerance, and it's kind of associated with immunosuppressant activity in the body itself. So it can create tolerance to the fetus and also may benefit your the allograft as well. However, there is a small possibility that you can have an antigenic stimulus provided by the fetus, which may trigger graft rejection as well. The risk of rejection may be higher in sensitized patients. So your patients who have PRA levels of greater than 0%, or in patients who've had blood transfusions that we kind of talked about a little bit earlier. And some of these risk factors for rejection during pregnancy can include a pre-pregnancy serum creatinine that's kind of elevated already from a baseline, and or fluctuating immunosuppression levels caused by pregnancy-related changes. Oh, excuse me. So rejection, it's similar to, so the presentation of acute rejection in pregnant patients is similar to non-pregnant patients. You can have asymptomatic elevations in serum creatinine and proteinuria, but you can also have kind of severe rejection as well. And you want to be cautious in these patients, in all kind of elevations of serum creatinine and decreases in GFR. And this is another reason why we might want to wait a little bit longer to encourage patients to get pregnant, and so that we can kind of monitor the baseline creatinine and see if they can kind of have consistent baseline creatinines, so that way we can kind of monitor them once they get pregnant. Rejection, you have to distinguish it from preeclampsia acute pyelo. You'll have to use ultrasound guided biopsy for these patients. And generally what we do to treat them is use glucocorticoids, which is our first line, and or increase immunosuppression. And you can have T-cell mediated rejection, and there's not really too many options for that in these patients. Rabbit ATG can be used, but there's not too much data. And in severe kind of antibody mediated rejection, there are cases where patients have undergone IVIG, Rituxan, or TPE, but these are seen more in ITP patients and TTP, not too much information in terms of ABMR in pregnant transplant patients. Okay, postpartum care, things will pretty much normalize a few weeks after pregnancy. And this is kind of the time where we have to keep a close eye on their creatinine and proteinuria, just to make sure they're not rejecting. Just because once the hormone levels start to kind of come back, it can cause more acute rejection in these patients. Last few topics. So breastfeeding, you can encourage patients in breastfeeding, but if they do want to breastfeed, they will need to be on this modified immunosuppression regimen, tacrolimus, pred, and either azo or cyclosporin. And it's because these medications aren't excreted too much into breast milk. But there's just not enough data for some of the other medications like mycophenolate cellcept or mTOR inhibitors to kind of let us, allow us to kind of say that we can use these medications in breastfeeding. So last few points here. Why do we prefer transplant over dialysis in pregnancy? So fertility improves physiologically, makes conception more likely in these patients. You have less overall invasive measures taken, so you don't need to go to dialysis very often, volume shifts. There's less overall time spent on dialysis. And outcomes are comparable to overall population, and kind of in terms of kidney-related disease, it's comparable to non-pregnant transplant recipients. So transplant is actually more preferred over dialysis in patients who want to become pregnant. And just kind of take-home points, it's a team effort. We encourage transplant for these patients, intensive dialysis for patients who want to have pregnancy while they're on dialysis, and you have to make sure you monitor the medications. And these are my references. Sorry, and I think I went up a little bit over time. I apologize about that. Any questions?
Thanks, Vic.
Great job, Vic. That was really nice.
Of course. Yeah. Sorry, Jessica.
No, I was just going to say, just so you guys are aware, and for fellows, myself and Annie Chen, we have a group that we meet with once a month with the high-risk OB, so that we do all the counseling of our CKD patients, dialysis patients, even transplant patients who want to get pregnant. We also do this with Dr. Joanne Zell with rheumatology, and we meet once a month and we go over the cases. So even if you have a patient, you can send them. We kind of monitor even other people's patients during pregnancy, give recommendations, and we do this once a month.
And Vic, so there's many of the faculty on the call actually have experience actually with the same patient, have carried pregnancies as a transplant patient. And then unfortunately, when the transplant has failed and they've gone on dialysis, we follow pregnancies as a dialysis patient. Actually, there is a patient at Rocky Mountain Kidney Center that we have overseen 3 of her pregnancy as a hemodialysis patient. So there is some expertise within the group to deal with this.
Hey, Jessica, for somebody who cares for mainly older gentlemen, is there a way we can listen in on that?
I'm sure there probably is. Well, maybe we'll just, if there's a whole bunch of interest, we just do it via Zoom. So I'm sure anybody can kind of join. I'll just talk with OB with Allie and make sure she's okay with it. But yeah, we envisioned lots of people joining, like trainees and stuff. We do it on Thursdays at noon, once a month.
Okay, thanks.
Thank you very much.
Very
everybody.
nice, Vic. Apologies, I was late.
Thank you.
Thank you.
Thanks, Vic.